Hey, it's Dr. Bill with just the tip of urology school discussing testes tumors. About 95% of the tumors that we will encounter are of germ cell origin. Those will break down into seminoma and non-seminomatous tumors. The majority of those categories will be under seminoma. It's the most common tumor that you will encounter of the testicle in men 20 to 40 years of age. Risk factors for this will be cryptorchidism, a family history of testes tumor, and intratubular germ cell neoplasia. About 2.5% of testicular cancers will be bilateral. So familiarize yourself with the types of germ cell tumors. Understand that it is most common in that young men's age group, but relatively rare compared to other cancers. Obviously, for a young man with this diagnosis, it's a devastating diagnosis. And oftentimes, out of embarrassment or fear, we'll find that patients are reluctant to present for definitive evaluation. Painless testicular mass is the most common presentation, and people tend to blow that off and try not, and often will not accept that diagnosis for themselves. When we see this in clinic, we get an immediate testicular ultrasound to confirm. Sometimes when we see ultrasounds for other reasons, mainly in my practice, chronic infections or infertility, we'll also see microlithiasis. Microlithiasis basically punctate calcifications within the testicular tissue. There's a lot of confusing information on this, but certainly in the radiology literature, there is a concern of an association of microlithiasis with testicular tumor. So I will get periodic ultrasounds, but most importantly, suggest and teach your patients on self-examination, just like breast cancer in women. Self-examination is very important and has led to early diagnosis, both in breast cancer and in testicular cancer. When we are evaluating our patient and an ultrasound confirms a testicular mass, certain tumor markers, AFP, beta HCG, and LDH are important for us to identify preoperatively, after surgical procedure, and after confirmation of a testicular cancer. We can recheck those hormones, and that will give us an idea of the tumor markers if they've come down. If they've come down to a normal level, that's good information. If they have not come down to an acceptable level, that's a indicator, a concern for evidence of metastatic disease. And when we're talking about surgical procedures, really we're talking about radical orchiectomy, approaches surgically through the scrotum or via a testis biopsy. Really not an appropriate way to go because of potential seeding in other areas of lymph nodes and contaminating the scrotal incision with cancer cells. So radical orchiectomy, basically a approach, a surgical approach like an inguinal hernia repair is appropriate. So depending upon the stage and the cell type, this will dictate what follow-up treatments are needed. Oftentimes we'll use surveillance, but depending upon what kind of disease we're dealing with, lymph node dissection, radiation, or even chemotherapy um, will be utilized. It's important. Remember, you're dealing with relatively young men who have their whole life ahead of them. And so discussions of hypogonadism, infertility, and even sperm banking is certainly prudent for the patient and family's point of view, and from a medical legal point of view to protect you as a provider. CT scans of the chest, abdomen, and pelvis with and without contrast are important. And as said before, postoperative tumor markers will be an indicator of persistent disease. An important pathology malady to understand. It can be very confusing. I suggest that you look at the AUA core curriculum and other types of literature and text for the NP&PA, but get an idea of basic cell types, get an idea of the appropriate workup, have an understanding that an ultrasound and is important, as well as the tumor marker assessments periodically. Get a comfort level in talking to the patient about serious disease and as also quality of life issues as far as sexuality, hormonal management, and infertility. These are things that are fixable, very frightening for this patient population, and something that as a caregiver in urology really need to feel comfortable with. Dr. Bill with just the tip of urology school and testes tumors.